Thanks. Right, thanks very much, Anne. So it's really a great pleasure to be here, and I'm going to try and share with you a little bit about what critical care entails within the context of anesthesia, because I am a specialist anaesthetist by training, but really probably try and challenge your thinking a little bit and make you aware of some of the real issues that we face in the intensive care unit and in the practice of critical care. So really, critical care is about pushing the envelope. And we really, we do it incredibly hard, and we really go beyond the norm in terms of looking after patients. So we will really keep people alive against all odds, as it were, and we really practice medicine at the limits of what's possible at the moment. So that is really critical care and the ethos behind a lot of what we do. And why do we do that? Well, in the anesthetic context, people have operations and surgeons like to do more and more adventurous things. And our patients who go for the procedures, they really, from their perspective, see things as, I want to live forever. And so we're caught in this conflict where surgery includes more and more physiologic trespass, and everyone wants to get better at the end of their procedure. So being a little more serious, and I think you've probably heard about this during the course of the week, or you will hear about it, in theatre, things have really become very high-tech. We do big operations, lengthy procedures on patients who are increasingly more and more compromised, more inherently unwell, with more background disease, on more medications, etc. And it's a simple truth that we cannot get patients through the operations that they undergo just by waking them up at the end and putting them back in a ward. So for some people, to be able to have a reasonable chance of a good outcome, it means they have to go to ICU afterwards. So that's the intensive care unit, or that's a bed in an intensive care unit. And just to say to you that from a medical perspective in the hospital, to a large extent, this is where the buck stops ultimately. So we are the pinnacle of care in the hospital, and anyone who's really, really ill would potentially get referred on to ICU. So we, fielders out there catching whatever comes our way, and it comes often unexpectedly. Patients go to theatre and they have a procedure and there are complications, etc. And so it's quite a pressurized, uncertain environment to work in. But obviously, it's not just the room. It's a whole group of people. And just to tell you a little bit about who we are, so that's my team of intensivists who work with me in the hospital. So there are 5 of us who are, or there are 6 of us now who are full-time intensive care specialists, and we really provide the lead in the care of the patients who are admitted to our ICU. And it's not just us, but a whole group of people. So we have nursing staff, a number of whom are actually specialist intensive care nurses. So they're not just ordinary ward nurses. We have dedicated physiotherapists, a team of physiotherapists who work with us, and amongst them, a number of them are cardiopulmonary specialists, so heart and lung problems. They specialize in that kind of physiotherapy. We have dietitians who work with us, so every morning, every patient gets seen and assessed by a dietitian so we can make sure they get the nutrition that they need to be able to survive. And a stay in ICU has been likened to running a marathon on a daily basis for a patient who's critically ill. So obviously, to stay in ICU and get better, we have to make sure you get the best of nutrition and supplementation. So our dietitians help us with that. And then we have pharmacists and social workers. And this morning on the ward round in ICU, I was just counting up how many people there were because I knew I was giving you this talk. And there were 16 of us who were going around. So every patient got seen by 16 people during the course of that ward round. And there were 2 of us who were intensivists this morning, plus another medical specialist, a host of trainee specialists, and then the physiotherapist, the pharmacist, the dietitian. Everyone was there. So the expertise that goes into critical care is enormous. It's absolutely huge, and the mind boggles at times. I think, when even I look at what we can achieve and who's working there, it's actually phenomenal. So just to tell you a little bit about an intensivist, and this is someone like me. So intensive care is a super speciality. So all of us who are intensivists, we all specialize in a field in medicine, and then after we've specialized, then we subspecialize or super specialize in critical care. And so intensivists come from a variety of specialities: anesthesia, medicine, surgery, obstetrics and gynecology even, but we then all go through the same training process in intensive care. And just to say to you that we're not really widely available, our level of expertise. We mostly work in the state sector, and there are a handful of intensive care specialists who practice in the private sector across the country. So in Cape Town here, in the Cape Town metropole, I'm only aware of 2 intensivists who work outside of state facilities. So the intensivist undergoes specific focused training. It's 2 years of additional time, and then they do an examination, get certified by the Colleges of Medicine of South Africa as an intensive care specialist, and then registered with the Health Professions Council, and then we can practice independently in critical care. And then just to say, there are really 2 broad spheres of practice or divides, and that is they're pediatric intensive care specialists, and then they're intensivists who work in the world of adult intensive care medicine. And I'm going to share with you this afternoon mostly the perspective of an adult intensive care specialist. So this super specialist that we have available to us is really, in terms of what we do in ICU, the master of organ failure. So that's really what we see ourselves as managing. We manage organ failure, and particularly patients with what we call multi-organ failure. So that's an intensive care specialist job, is to look after patients with multi-organ failure. And as I say, a number of patients who will come from theatre, and we'll discuss a case just now, unfortunately end up in this kind of perilous situation. So if we manage organ failure and we provide organ support, I'm just going to go through with you some of what's possible, and we're going to look at which organs we perhaps have more tools to support, and we're going to start off with the heart. So just to say that as far as supporting the heart goes, really some of the key things we do, we put lines, what we call lines, into people. So we put tubes and pipes into them, into their blood vessels, and we administer drugs through those lines to support their heart and improve its function. And it means patients get connected up to a whole host of syringe drivers and infusion pumps to manage these drugs that go into them. And as standard practice in our ICU, we have the ability to put 8 syringe drivers around a bed, and we have the ability to put 8 infusion pumps. So that's 16 different things we can pump into someone. And then we connect this, we also make use of fancy monitors then to give us information and to give us data on what's actually happening to the patient's circulation, the function of their heart, the delivery of oxygen, the flow of blood through various organs and tissues. So just one thing I want you to keep an eye on as I go through these slides is just to realize how invasive we are. Okay, we do things to people in ICU, and sometimes it might not be all that great, and I'm going to make you think a little bit about that at the end. Then perhaps the pinnacle of supporting the heart and the circulation is something called ECMO, extracorporeal membrane oxygenation. And this is a bypass machine, a photo of a bypass machine taken in a theatre. But really what we do in ICU now is we try and take this kind of technology and bring it into the intensive care unit so that we can replace someone's heart and lung function completely artificially in the intensive care unit. And we're busy with a project to upskill ourselves with this at the moment. So this is a slide. This is just a patient. This is from Australia. This is a patient who is on ECMO and being transported. And I'm sure you'll realize it's actually hard to see that there's a person in the middle of all of that anymore. So an incredibly, incredibly complex environment with a huge amount of invasiveness in terms of the patient. So if we move on a little bit and we look at other organs that we support, then we very commonly support the lungs. And to be able to support the lungs, we have to intubate people. So we put a PVC pipe into the patient's trachea through their voice box, through their cords, so the patient can't talk anymore, they can't swallow. It's very, very difficult for them to communicate. And of course, as you would imagine, that's a very uncomfortable situation to be in. But it's an absolute necessity in terms of being able to connect the patient up to a ventilator, so to a machine that can then artificially push a mixture of gases in and out of the patient to support the function of their lungs and the function of their gas exchange. And there are different types of ventilators and things that we can employ. So this is a high-frequency oscillator. It's a ventilator we use not all that commonly in adults, but we do have it available to us. And this little machine has got a piston that pushes gas in and out of the patient. It's situated over there. And we make adult patients breathe at about 180 breaths a minute. So it's very, very fast. And this machine sounds like a bus idling when it's actually running, the noise that it generates. So again, a patient has to be intubated to be connected to this machine, and it's a very noisy environment to be in. Other organs that we support commonly, the kidneys. We see a lot of renal failure in ICU. And in terms of supporting the kidneys, again, we have to put lines in. We need to get intravenous access so we can remove blood from the patient, process it through a machine, and pump it back in. So this is what we would call a femoral dialysis line. It's sitting in the person's femoral vein in their groin. And we then take that dialysis circuit and we connected it up to a dialysis machine. So the patient's blood runs through this machine. It's pumped through. There's a filter there that actually does the work of the kidney, as it were. So we have a dialysis solution that runs through there. And the blood then gets exposed to a dialysis solution across a very, very thin membrane. And once the blood has been cleaned, as it were, in that filter, then it gets returned back into the patient. And again, an invasive kind of procedure, and fraught with potential problems. You can imagine having someone circulating blood running all around in these pipes carries with it some risk. So these machines are increasingly complex, and we can do a number of things with them other than just simply replacing a renal function. But just to say that the technology exists. It's expensive technology, but we have it available, and we employ it pretty routinely. Then other organs, we can look at things like the liver. And just to say that as far as supporting the liver goes at the moment, there's not a huge amount available to us. This is the kind of thing that's in the pipeline. So this is an artificial liver. These things are being developed. The principle is similar to a dialysis machine where we've got an artificial kidney, but now we take liver cells that have been grown in a laboratory, and we load them into a filter, and then the patient's blood runs over these liver cells and back in. So really at the moment this is experimental, and some of the people from our department are busy with work looking at these kind of artificial livers in the laboratory, and looking at trying to support pigs from taking pigs' livers out essentially, and then trying to support them with a machine like this. And then last of all, to say the other organs that we support commonly is the gut. And I mentioned to you the importance of getting food. And so again, in terms of supporting the gut and providing nutrition, we've got a few options. We put what are called nasogastric tubes in. So this is a tube that goes in the patient's nose and then down into the stomach so that we can feed them. There are also options to put pipes in directly through the skin into the stomach or into the small intestine. So this is what's called a PEG tube. It's a percutaneous gastrostomy tube. And so for some patients where we cannot put a nasogastric tube in, so people who've had their esophagus removed, or there's no passage there for a tube anymore, then things like this become an option. Again, invasive things to do to people. And then last of all, from a nutrition point of view, this is a slide just off the web, we have the ability to feed people completely intravenously. So they don't have to eat any food and put it through their intestine, as it were. So we have mixtures which contain all the nutrients that you need, and then we put these into patients. So unfortunately, our patients who are on TPN don't often really look like this. This is an Australian gentleman who was in the news recently. So he's a person who's on lifelong TPN, and the Australian government wanted to withdraw his support for TPN because they say he's overweight, and they'd only continue to fund him from a TPN perspective if he lost 6 kilos. So there was a huge amount of press about this in Australia in the last few years. So again, he's probably, you just start to see the kind of person. So he's been supported medically, but you could argue about whether or not it's appropriate, what his quality of life is like, etc., etc. So in terms of the organ support, then the real concept is one of complete care. So we can really take over and support a huge amount of organ function in a very, very complex environment. But having said all of that to you, just to say that in addition, all of us who are intensivists are really very, very dedicated patient advocates. And a big dilemma that arises on a daily basis in ICU is we can do all of this stuff, but because we can do it doesn't mean we should do it. And the patient advocacy comes in terms of, so what is right? What is morally and ethically the right thing to do for the patient? And you can, practice medicine where you just do everything that's possible. But in the intensive care environment, I don't think that's always a great thing. So where does all this happen? Well, I told you it's in the ICU, and I showed you a photo of a bed there. But just to say that in South Africa, we've got 3 tiers of intensive care. So we've got Category 3 ICUs, which are tertiary intensive care units, like the one that I work in. And then there are Category 2 ICUs, which just do single organ support, and Category 1, which is high care. So just to say that in the South African context, really, the Category 3 ICUs are only really functional in some of the university-associated hospitals. The private sector doesn't really have the ability to offer that. And most of what's called ICU in the private sector is, in fact, Category 1. It's high care. Okay, so it's a different profile of patients to those that we have in our intensive care units. But all of them are just commonly referred to as ICU. So, someone's in ICU, they would be in any one of those. All right, and all of this is backed up by a 24-hour service, so we have access to theatre and anesthesia and surgeons. So if our patients in ICU go off at night or there's a problem, we can get immediate access. Radiology, laboratory services available to us all the time, catering, environmental hygiene, etc. Really, the intensive care then is a world that never sleeps, and there are people there, loads of people, 24 hours a day with the patients taking care of them. And so that gives you a little bit of background as to kind of what we do in ICU. But I want you to consider this, okay? A patient comes to ICU. We're going to make it a little bit more real, okay? So this is a 64-year-old gentleman. He's just had a big abdominal procedure in theatre. Maybe he's had a procedure on his aorta, a big blood vessel in the abdomen. One of the things that we do sometimes is replace them when they become abnormal. And he's intubated, means he's got one of those pipes in his trachea, so he can't talk. He's on a ventilator, so the machine's doing the work of breathing for him. We've put him on some drugs to support the function of his heart through a line, like you saw in that slide, the neck. And his urine output is poor, so maybe his kidneys aren't doing too well. And things are looking tenuous. And that's a pretty regular situation. And so then the family come in, and they say, will he be okay, doc? Okay, is he going to die? Those are probably the 2 things we get asked most often. So just to say, to get into ICU, okay, there really needs to be a serious risk of the patient dying or of developing complications. So a lot of people are not aware of that. When someone comes to ICU, they only come to ICU because they're in deep trouble already. Okay, that's the important thing. And then importantly, they only come to ICU if there's serious potential for their benefit. There's no good putting someone who's not going to benefit from the care into that kind of environment. And unfortunately, it's a reality in our country that to some extent this gets ignored, particularly in the private sector. So if there's money to be made, the patient goes to ICU, and there may not be the potential for benefit, but the therapy gets started, and that obviously creates huge, huge problems. For our ICU overall, if we look at our emergency admissions, we have a pooled mortality, a kind of average mortality of around 30%, so 1 in 3 of our patients die. That's a kind of the outcome that we deal with most of the time. And there's a very, very high risk of morbidity, so patients get harmed while they're in ICU. And as I say, we do all these invasive things to them. You've got to realize that there's a risk of complications. So if we look at why the complications, this is just an example or a photo of a manifold. This is managing the drugs and things that are going into a patient, okay? The things that are supporting their heart and maintaining their blood sugar and maybe the nutrition, the TPN, etc., etc. This is a very, very complex environment to work in. And it means then, unfortunately, there's a risk for complication when you've got a huge number of variables that you're juggling. And also, if we look at the patients, then our problem is that no two patients are actually the same. Okay, so everyone has different fingerprints. Everyone responds differently to an insult. So if one person gets a pneumonia and another person gets a pneumonia, they don't respond to the infection the same way. If someone has an abdominal aortic aneurysm fixed, they don't respond or behave the same way as someone else. So there's this huge problem of biologic variability that we deal with. And we obviously try and look for patterns, as you know, happens with the classification of fingerprints, etc. But the huge biologic variability lends a lot of uncertainty in this complicated environment. And so, to a large extent, things are not predictable, or they're not as predictable as you would perhaps like to believe they are. And so, just when you think it can't get any worse, it can. And just when you think it can't get any better, it also can. And you know, when we have patients in ICU and the family come and talk to us and we say, listen, we're going to have to wait and see how he or she does on the treatment. They say, but surely you must know, and surely you can tell us if he's going to get better, etc. It's not that easy. Okay, so when you remember the questions, will he be okay, doc? Already you realize the patient who's in ICU has a high risk of not being okay. Okay, that's something a lot of people don't realize, is that these people are, as I said earlier, in big, big trouble. And is he going to die is a real risk. So now, just in terms of dealing with this, is he going to die, I want to share with you something called the trajectory of life. So we're going to look at time along the graph, or along the x-axis over there, and we're going to look at the vitality of life, as it were, on the y-axis. And we look at where life starts. So a person's born, and we'd all agree that, you know, that's where life starts. Or you may question it and say, well, is it just at birth? And we could make an argument perhaps about life being there before birth. But by consensus, we agree that when someone's born, then they're alive. So there's debate about what happens in this early part of life, and there's debate about what goes on at the other end as well. Anyway, the person's born, and then obviously you thrive as a child, and you grow and you prosper, and you really hit your biologic peak relatively early in life. So by early 20s, that's it. And then afterwards, for most of where all of us are now, we're on that long downhill road. Okay, and that's the reality of life. And it means we're heading towards this point over here where we will die. Okay, so, you know, when the family asks you, so will he die? Well, the answer is yes. Okay, and we can make arguments about when someone is actually dead. And so, again, by consensus, we say when someone's heart stops, then they're dead. Or perhaps in the setting of brain death, we've got some definitions and criteria. But the truth is, there's a little bit of a woolliness about this period at the end here. And we have to realize that if we say someone's dead when their heart stops, there's a period of time before that when they're dying where death becomes an inevitable thing. So we might say, oh, the patient's still alive, but actually, technically, they're dying. There's nothing more we can do to change this process anymore. Okay, the patients crossed a bridge over which they're not going to come back in their life. And for the majority of adult patients in ICU, then we meet them somewhere on this part of the road. And it's important to look at what happens on that part of the road. So it's nice to believe that if we're somewhere on this curve and we get sick, then we obviously fall off our vitality curve quite dramatically, and we spend some time in ICU where we're really unwell, and then we get better, and then we join back onto this curve of where we were before, and we carry on this road kind of to the end. That's kind of the nice idea of what happens. But it's not the case of what happens to patients who get admitted to ICU. So the reality is more like this. What happens is you get sick and you come to ICU and you spend some time there and you get better, but you never get back to where you were before. Okay, so that's an important thing to realize. For a lot of patients, barring the very young or people who we admit with infectious diseases where we can treat the infection and make it go away, This is the reality. And then when you join back onto your line of what's happening to you, not only do you don't just go back onto the same kind of slope, but in fact you're destined to die sooner. So putting people into ICU and doing all these things to them is not an elixir of life. We don't take people back to their pre-morbid state, how they were before they got sick. And a lot of people don't understand that. So we take a patient, we put them in ICU, we put all these pipes and bits and pieces into them, and the truth is their life is never going to be the same again. And that again is an expectation which the public doesn't have. The public thinks, oh, we'll go through ICU and everything will be fine. And so the will he be okay, doc, is how do you answer that question when you know this is actually what's going to happen? So will he be okay? No, he won't be okay. He probably won't ever really be completely the same. And will he die? Well, it's very likely he may die soon, but ultimately he's going to die in any event. So it's a tough reality. And unfortunately in ICU then, this is where we know a number of our patients are heading, either in a rapid rate or at a little bit slower, but we need to be cognizant of it. And for all of you, just as members of the public, is to be aware that this is what happens. We don't work miracles. So as far as long-term outcome goes, this is now looking at these, this sort of trajectory of life. This is the only bit of science I'm going to share with you this afternoon. So this is just a paper from one of our journals. This is a follow-up study in terms of goal-directed therapy. So a long time ago, a study was done in the UK where patients who were having high-risk surgery were monitored very intensely and optimized and taken care of to a huge extent with a lot more monitoring and therapy than was ordinarily used at the time to see if it couldn't help people get through their operations better, that we could have better outcomes. And of course, the years have gone by, and what they've done is they've gone back to look at those patients who were in the study 15 years ago and see, so how are they doing today, to try and pick up where they are on that trajectory. So this is something some of you may be familiar with, but it's a thing called a Kaplan-Meier survival curve. And we use it a lot in medicine. And really what we look at here is the number of patients who are alive, so the percent survival, and we look at what happens over time. So this is 15 years, okay, across the bottom there. And in terms of this study, there were people who had this invasive therapy, they were called the protocol group. And you can see what happened is that over the 15 years, there's been a steady attrition in the number of patients who were enrolled in the study. And there was a control group who got standard therapy. And you can see there they go on the purple line. So again, this just highlights to you the fact that it's an unfortunate reality that when people get out of hospital, etc., they continue to die off. No one lives forever. And you can see in terms of these two curves, there's a big difference here early on. So the people who got the invasive therapy, the protocol, did better. There were more deaths in the control group early on. But then to a large extent afterwards over the years, these two lines are in fact parallel. Everyone is dying off in both groups to an equal extent. So that's a Kaplan-Meier survival curve. And that's just the long-term outcome in terms of the study. But we can take this information and we can break it up a little bit more. So what I've got here, these are all complications. So we're looking at, and there were defined complications, cardiac problems, renal problems, lung problems, people who needed the kind of thing we've been talking about in ICU. So you can see for patients who had no complications, they're in the green line, and for patients who had complications, they're in the purple line. And you can see there's a much more rapid rate of attrition in that group who developed complications. You can see here the slope of this line. People are dying faster in this group than in the group who had no complications. And then we get to a point in time where there are obviously some tough nuts who are just hanging on there. So they've made it through their illness. Then if we look at specific organ dysfunction, so this is respiratory complications, people who developed a pneumonia or needed to be on a ventilator. Again, you can see if they didn't get on a ventilator, that's the survival curve over there. And for patients who had complications, lung complications, and were on ventilators, etc., you can see that a number of them died early on. But these lines are probably a little bit more parallel, which tells us that respiratory complications, people can die of respiratory complications early on, but if they get through them, then there probably aren't as many long-lasting consequences. They do have less effort tolerance, they can't do as much work, they can't walk as far, etc., but they tend not to die from their respiratory complications. Now, this is more concerning. This is cardiac complications. So these were people who had myocardial events. Some of them had heart attacks, or they needed to be admitted to ICU to get drugs to support their heart function. So now you can see patients with no cardiac complications. They're all out there in their Kaplan-Meier survival curve. But for patients who did develop complications, you can see here, after 10 years, there are no survivors. Everyone is dead. So if they got a cardiac complication, no one lived longer than 10 years. Okay, so they fall way off that curve compared to the normal population. And then the last panel is for patients who developed renal complications. So if they needed to get dialysis in the post-operative period. So now you can see what's essentially 5 years. There's no one alive after that. Okay, so the bottom line is getting complications in the post-operative period and needing to come to ICU carries with it huge risk. Okay, so you remember the questions. So when the family say, "Will he be okay, doc?" That scenario I sketched for you is someone who's come into ICU. It's a common thing. He's on a machine to help him breathe, on a ventilator. His kidney function looks as though it's not doing so well, and his heart, he's needing drugs to keep him going. So will he be okay, doc? To the family may mean, well, he's alive right now, and maybe we'll keep him going in the immediate future. But the truth is, in the long term, will he be okay? Probably not. Okay? And again, is he going to die? Big risk. All right, so the last few slides I want to go through with you now is just from your own perspective to consider ICU and intensive care. So it's a real thing that all of us may be faced with the need to be admitted to an intensive care unit. And if that opportunity arises, or if that necessity is there, so what are we going to decide? Or what do you want to decide for yourself? Do you want to go there? Or don't you? And, you know, if this stopped, would you miss me? The reality is often in the situation when you're going to ICU, you're not going to be making any decisions for yourself at all, okay? So have you thought about yourself in terms of this kind of thing? And it's something it's an uncomfortable thing, but we actually need to speak to our families and our spouses and our children, etc., and say, you know, this is what I want out of my life. And we all have to realize we're going to die at the end, and do you want quantity or do you want quality? And that's the hard reality. So this is something that we have to think about. And I'm always so dismayed or disappointed, although I suppose it's the reality, is how few people ever talk to their family about these kind of things. Ever, okay? So possibly the worst part of practicing medicine in ICU is the situation where you admit someone to ICU, they're on a ventilator, they're intubated, they can't talk, they're semi-conscious, their kidneys are failing, things are not looking good, and the family say, oh, can't you just wake him up one more time so that we can talk to him? Or I just wanted to say this, you know, to my dad or to my son or whatever. And unfortunately, those opportunities are not there. Often they're not there. And so to make sure that we've discussed our wishes for our own lives with our family, and also that we don't carry too much baggage with us, because the reality for most of our patients in intensive care, they had no intention of going there, and they never realized that was where they were going to end up. It's a completely unexpected event. So just to say to all of you, then, you know, end-of-life planning, it's never too early to plan, okay, and it's never too late to start. So these are things that when families come, when we admit patients to ICU, almost inevitably, the first few questions we ask the family is, so what has your dad or your son or your daughter said about their life? What are their wishes? And do they want to be alive at all costs? Or, do they want quality? So we just recently had a young man who got admitted to ICU with a bad head injury, a really, really bad head injury, which injured his frontal lobes of his brain completely, which is the part of your brain that really gives you your personality. And he had other injuries, and we really didn't know that he was going to survive. In fact, we all believed he wouldn't survive because of the extent of his injuries. But we discussed with his family what they wanted, and they said, no, we would want him, keep him alive at all costs. He's a young guy, and he's got his life ahead of him, etc. And so we did, and he's got better. He's been discharged from ICU. But the person that the family are taking home is not their son that came into hospital. He's never going to be the same person again. So they're taking a stranger home with them who's never going to function at the same level that their son did. And you I always wonder, so is that a success? And I think the family don't appreciate that. They felt that they would take their son home. But obviously their son is the person in the personality, not just the body. And I think that's something we need to be cognizant of. So some things to ponder then in terms of ICU. ICU has a lot to offer. We have an enormous amount to offer our patients. But suffering, pain, and hurt is part of it. Unfortunately, that's the reality. We can't do all of this, and I showed you the lines and the discomfort, etc. for patients is a real thing. Our patients really hurt because of what we do to them. So we give them drugs to take their pain away, and we sedate them. We try and make them comfortable, but this is no, picnic. This is hard on the patient, and it's hard on everyone who looks after them. Our individual response to illness is as unique as our fingerprints, and I've said that to you. So it's so hard to know how any individual patient will do. We kind of know in general how people with a pneumonia and renal failure will do in ICU, but obviously the individual patient, there can be variability. And as I said to you, to remember that everyone dies in the end. Okay, that's an important thing. So while everyone's uncomfortable about dealing with the reality of death, but it's something that we deal with in ICU all the time, is to realize that death is resented and feared because it brings an end to human joy, but it also brings an end to fear and pain and suffering. And part of what we have to think about is allowing our patients a good death, not just treating them and putting pipes into them because we can. So to kind of end off to all of you is to emphasize to you that in terms of this and in terms of ICU and what we can do, you actually decide. You have the power to decide that. If you don't make a decision, then other people will make the decision in what may be your best interests, but may well be in their own interests. Okay, and that's a reality. If your family are making decisions for you, often your family will make decisions for you that are in their interests, not just in your interests. And they obviously have a huge vested emotion in the whole situation, and so they're not necessarily clear. And then otherwise the intensivists, we will make decisions for you, and we'll make decisions in terms of what we think is best, and there we really look at quality of life, etc. And most of us who work in intensive care, when we see the potential horrors of what surviving ICU can be, is we say, okay, if we can't give someone a reasonable quality of life, then it's probably morally not right to keep going. And then we have conflicts with families. We say to the family, we think your relative's not responding to the therapy. We're anxious that they're likely to have a very bad quality of life afterwards, and we think we should curtail our therapy. We should allow the person to die naturally. And they say, oh no, you can't do that. And it gets very, very difficult. Anyway, that's all I have to say to you, and so there you go. In 3 words, I can sum everything up I've learned about life. It goes on. Okay. So I hope that gives you a little bit of insight into what critical care entails to some extent. Thanks very much. So questions? Yes?
Can you comment on ICU psychosis?
So,
I've had heart surgery, and in the course of that period, had 8 days of ICU psychosis. What I really want to know is there any relevance as far as the anesthetic is concerned when it comes to that problem? The reason I'm asking is because if I have to go back, I'm damned if I'm going to have an anesthetic again.
you might find it uncomfortable to have a procedure without an anesthetic. So ICU psychosis is a real thing, and it's representative of brain dysfunction. Okay, it's brain dysfunction in critical illness, and it's a not uncommon thing which is very distressing to family and relatives. And the individuals, and I'm sure you probably at the time were a nightmare to anyone who was trying to look after you, and you don't remember any of it at all, but it's a very real entity. And just to say that I think it's unfair to blame anesthesia for that dysfunction. It's what happened to you in that operation and the physiologic trespass, and what happened to you afterwards is more likely the cause of the brain dysfunction than the anesthetic. So we can give lots of people an anesthetic and wake them up, and they won't necessarily get brain dysfunction. But in the ICU environment, it's a common problem. Very, very common. And it relates to the insult, whatever it was that you had, that whole operation, etc., and all that went on around it would have been what caused that problem. So it wouldn't mean that you're necessarily going to get delirium or psychosis again if you have another procedure. Okay.
What is it?
But I hope you don't. I hope you don't.
What is it, psychosis?
So it's a state of disordered thinking. So the person is, when we would look at them, we'd say, oh, they're confused. Okay, the patient. So just to give you an idea, and it can be quite subtle. It can either be very easy to see the patient's just stark raving nuts, thrashing around in a bed and shouting and going crazy, to something that's a lot more subtle. So to give you an example, we had a patient in our ICU. This is when I still worked in Joubert, and the ICU there had some big ceiling fans, and he said, oh, won't you turn the fan off, please? And we said, okay. And now you think, well, maybe he's uncomfortable with the breeze or whatever it is. So I said to him, why do you want the fan off? He said, no. He said, there are people coming through the ceiling. He said, and when they come through the ceiling, those blades are chopping them. He said, and it's a bloody mess. He said, so you know, what sounded like a very reasonable request. He was not a full box of chocolates at the time. There's no doubt about it. So the amount of disordered thinking or brain function someone can have can be from very, very obvious to very, very subtle. And there's a whole spectrum, but it's common. Okay, it's common.
Does it start in depression?
No. So does it start in depression, or I guess even would it lead to depression? So this kind of organic brain disease that we're talking about now is not a mood disorder from a psychiatric perspective. So it's a different entity.
Can I ask, you said you know that there's nothing more you can do. At what, on this spectrum, at what point do you really know there's nothing more you can do?
So what we do is, obviously there's a physical limit eventually to what intervention we can go. So there's a maximum of therapy we can give. And if you get close to that and you see the patient's not getting better, because then you kind of realize things are going to go badly. So just to say to you, I think also maybe from a philosophical point of view is to realize that in ICU and even in all of medicine, we don't make anyone better. Doctors don't make anyone better. All we can do is create an environment where we take care of the things that are threatening the patient, and the patient heals themselves. Healing is something that happens from within. So we can't make someone better. All I can do is try and create the best environment possible for them to get better in. And when you see that the patient from their side, there's no healing, they're not getting better, it's usually they're dying. And it's identifying that point in time in which there's nothing coming from the patient's side anymore. is realizing that you've lost the battle. Whereas you get a patient and you put them on a drug to stimulate their heart and their blood pressure goes up. There's something happening from their side. If you're in a situation, you give them the drug to make their blood, and nothing happens. You kind of realize from the patient's side there's nothing coming through.
That's fantastic.
Okay.
Thank you.
All right.
Good answer.
Okay. Yes. So first of all, living wills in the South African context aren't really valid legal documents, okay? But they're very useful to us as clinicians because it's evidence that you've given some thought to what you want to have happen to you, and it gives us some direction in terms of planning. So we've had some patients who've been referred to our ICU, and they're going to need to be ventilated, and we bring them in, and the family come and say, oh, no, look, Gran signed a living will. You must just stop this. Just stop it. And you say to them, okay, I realize Gran signed a living will, but you need to understand, I think that if I ventilate her overnight, tomorrow morning I can take the tube out and there's a good chance that she'll be better. Then people say, ooh, okay, they're pretty sure Gran didn't mean that kind of thing. But if I say, oh, this is going to be 3 months in an ICU with no chance of a good outcome, etc., then what is in that living will is very useful to guide us. And so I think the big benefit of living wills is in the discussion that we have with family, etc., they're very, very useful. And at least the person has expressed some opinion on what they think is reasonable with what should happen to them. So I think they're fantastic from that perspective. But again, there needs to be a little bit of sensitivity and awareness in terms of interpreting them, because I think people aren't always aware of what the implications of their disease is. And the reality is some people come to ICU and they actually do really well and we get them out quite quickly. And I think in that setting it would be crazy to deny someone the care where I think that wasn't what was in their mind. They worried about the bad outcome, the poor quality of life. So, yeah. But they're nice when they're around. Yes?
On that same note, to what extent can you know, obviously it's not perfect, but say if someone came in with a traumatic brain injury, I know that I do not want to live if my brain's not fully functional, and I wouldn't want that on my family. But to what extent will you know, her personality might be a bit adjusted, or she'll have no memory of this, or she's referred to a 4-year-old?
So again, there's a spectrum of injuries and things. So if you get admitted with a head injury and you've got a small contusion, so the actual amount of tissue, brain that's injured is very, very small, and we look at you, at your neurologic function, then it's reasonably easy to predict a good outcome. You may have your head injury and you're just a little bit confused. Or you may have a head injury and we look at your scans and your pictures and we see there's an extensive amount of brain injured, and we can score you, we can try and evaluate your injury. We say, you know what, this is a very, very severe injury. And we know then we can predict that you've got a good chance of surviving with very, very poor function. So you may be persistently vegetative. You're never going to wake up again, but we can keep you alive. So we're quite good at identifying those kind of big outcomes. I think the big difficulty we have is when the family won't accept it. That's very, very hard. So we have someone who we realize is going to be vegetative. You can see their brain is crutched. There's nothing left there to leave them as a normal person afterwards, even potentially. And you've got a family who, no, you must keep trying. Won't you get better? And then, this morning I think he moved a hand, or, you go through all of that. But, yeah. Okay. Does that answer your question?
Yeah.
Okay. Right, up at the back there. So what do we do about it? We go through many, many, many meetings with families and, impress upon them all the time. We go over the same points again and again, that the person is not responding to therapy. We're uncomfortable as doctors keeping them alive. And I think for most of us, I can't keep someone alive, just because I can. It's like keeping a fish in a bowl at home and stirring it and doing all kinds of things just because you can. That's not fair. And is eventually to make patients, to make families realize that their family member is dying, and they, to bring them around to that kind of thinking. It's a very difficult, very traumatic process. Our social workers and counselors help us. And when you get families who are in complete denial, it's a very, very difficult thing to deal with. But we do. We just keep trying. Keep talking. Right.
How do you as a doctor survive that working environment where, say, 50% of the patients will not make it? Yeah.
So I think for intensivists, it is an emotionally difficult job, and there's certainly a very high incidence of burnout in people who work in intensive care. That's a reality. I think obviously different people cope with it to a different extent. My own feeling is I didn't make anyone sick deliberately to put them in ICU. So I'm not responsible for the fact that they're there. And the best I can do is try and offer them good care, and for some of them, hopefully make them better. But those who don't make it, I didn't put them there. I didn't hurt them.
Doesn't that make you hard?
I don't know that it makes you hard. I think it's reality. So I will do the best I can for the people who are there, but I didn't make them sick. So I don't feel guilty if a patient doesn't survive. That I can't. And I think when you get into that and you start to feel guilty, it's a big problem. But yeah, we have a group called ICAS who we arrange to come and do counseling sessions with us in ICU on occasion. So they come and they talk to us about burnout and about this and that, and we have a little huddle cuddle together, the intensivists and some of our staff, and discuss some of the patients and our outcomes. Yeah, but it can be difficult.
How many patients do you have a year?
So at the moment we're putting about 1,500, just less than 1,500 patients through ICU a year. In the units that we look after, yes. But which is small if you look at the volumes that other departments in the hospital will deal with. So if you look at anesthesia, I mean, anesthesia is doing tens of thousands of patients a year, 25,000 patients at Groote alone. So, ICU is actually small.
It must be very expensive.
Yeah, so we are expensive, and we have big debates about our budget, because we spend a lot of money on a few people, and there are lots of other clinicians in that who want to spend a little bit of money on a lot of people. And the reality is you have to have some kind of balance in the system, for your different levels of care, so primary health care, etc., all the way up to tertiary health care. And, I think most of the public accept that we want to try and provide as much health care to as many people as possible, and we need a balance of basic care and we need advanced care. And the advanced care actually supports a lot of the system along the way. So one of the big things I do is I teach and train registrars or trainee specialists who come from surgery and medicine, etc., and they learn to look after critically ill patients in ICU, but then their knowledge they can apply to looking after patients who don't necessarily come to ICU. So the spin-off of an ICU is bigger than just those patients. It's the training, the opportunity, the knowledge base is much bigger, yeah. Yes. Yes.
Just a comment, the ICU psychosis was the most frightening thing
Okay.
to witness, because I didn't know, and they were so busy trying to sort it out that, yeah, but it's okay now. It's fine.
You think? You sure?
My question is, you said that in your unit, people never reach the level that when you do that graph.
Yeah. So look, so some people do get back.
No, but that wasn't my question.
Okay. But for a lot of critically ill people, no.
But we obviously not talking about the ICU units in most private hospitals where routinely after a procedure you may be there for the night or 2 nights or 3 nights.
Absolutely. So that's high care. People will have an epidural put in, they have a knee done or a hip done, etc., and they spend a night. Okay.
There was a transplant
Yes.
patient there at
Yes.
the time.
Yes.
So are you saying that those patients will not get back onto the curve?
So for a number of patients, unfortunately, yes. So, and now you must realize when I say get back onto the curve, obviously we can look at, that curve has different descriptors that we can use. So someone may get back, they may survive their critical illness, and ultimately their longevity isn't impacted on much, but their level of function is. So, you know, we look at some of the respiratory problems. So people will be short of breath a lot easier. They can't walk as far. Physically, they can't exercise or do as much as they used to be able to. But their longevity isn't necessarily impacted. So now, did they get back on the curve or didn't they? The reality is they didn't get back to where they were. And so for a huge number of people, the reality is they won't get back to exactly where they were. For some infectious diseases, and I say infections because an infection is something you can get and we can treat with antibiotics and we can make it go away completely, then the outcomes are a lot better. So we have a bigger chance of getting people back to their pre-morbid level of function. But the reality is for a lot of other patients, they don't get back all the way there. And that can be either in, you know, dramatic fashion, so now they're bed-bound after they come out of ICU, or it may be quite subtle. So, you know, you may have someone who says, oh, you know, I used to be able to run and I did marathons and that, and now I just can't anymore. And that may be you know, they haven't got back to their baseline. They may have a very good baseline after they get out of ICU, but they're not actually back to where they were. And so it's just something, as I say, I put it there just so that you're aware of it, because the general sort of expectation is, well, when you get out of hospital and out of ICU, you're going to be fine again. And that being fine again is a difficult thing, subtle, as to how fine is at the end. Yeah. Okay. Yes. So I've spoken to the staff that I work with. They know exactly where I want to be admitted and who I want to have look after me and what my expectations are. Yeah. And I think for most of us who work in ICU, we are inherently a lot more cautious or a lot more circumspect about what we want to have happen to ourselves, because we see the reality of what goes on. I don't want to be in my intensive care unit and survive to be just a survivor. And I think quality of life is a big thing to think about. And as I say, at the end, you've got to realize you're going to die one day in the end anyway. So do you want to hang on just because you can, or do you want to at least enjoy the life that you have? And I think for most of us, that's what we actually want. So those different tiers of care are all described in terms of the staff and the facilities. So for example, our tertiary ICU, there's a doctor there on site 24 hours a day. A patient will get seen. We do rounds at least twice a day. The whole team will come and look at the patient. A high care, you will probably get seen by a doctor once in the day. There's no doctor present in the intensive care unit. You'll get looked after by the nurses who work there. And then the number of nurses per patient also changes. So in a high care, you'll often have one nurse to about 4 patients. In tertiary intensive care, we work on a minimum of 1 per patient, and sometimes we have 2 per patient if the acuity is high. So then you've got, you know, a dedicated person, just nursing staff, looking after one individual patient. So those are the kind of things that divide those categories up, is really the level of resource that's available to look after the patient. Okay. Right, up at the back there. Yes. In theatre, it still gets used. I use it. I will still give anesthetics. Anthony will update you on it. It's a good drug. Not very environmentally friendly, though. So. Okay. All right. There we go. I will go one more question. Sorry, and then we're done. Okay, so that's a big question. So I'll tell you what we say about oncologists in medicine. Okay, so we say, you know why undertakers nail the lid of a coffin down? Okay, it's to stop the oncologist giving one last dose of chemo. And so the philosophies, and in different specialities in medicine, you get different philosophies. So I could never be an oncologist. You ask me, 1 in 3 of my patients, oncologists have much worse outcomes in terms of their patients. So they're a different group of people. But I think in oncology, the one thing that doesn't happen enough, and I look at oncology patients who get referred to ICU, is those discussions about what does the patient want. And the reality with chemotherapeutic drugs is a little like what we do. They actually hurt the patients. It's not nice to have chemo. So, you know, you've got to discuss carefully with the patient what the outcome is likely to be. And I mean, I see patients where the outcome is likely to be miserable, who get put on chemotherapy, which just destroys the quality of their last bit of their life. It doesn't buy them more life, it just buys them more suffering in the bit of life that they have. And that, I think, is a no-no. But again, that's the kind of discussion that has to happen between the oncologist and the patient. You know, what do you want? Or what do I want out of my treatment? Okay. All right, we're done. Thanks very much.